Well, thank you very much. It's a great privilege to be here. I want to thank Lenny for inviting me. It's also fun to see many of you that I know and friends in the audience and who played a role in what I'm going to present. So I want to talk a little bit about ALL in adults. I'm the chair of the ECOG Leukemia Committee, and working with our intergroup colleagues from the Alliance and SWOG, some of the studies that we have done. And a dear friend is in the audience, Adele Fielding. I want to talk a little bit about the studies that we did through ECOG with the NCRI, the former MRC in Great Britain, and Adele is responsible for much of what I'm going to show here. These are some of my disclosures. So I want to talk a little bit about some of the data in AYA and older adults. I won't dwell on that. There's going to be other speakers talking about that. I want to talk about blinatumomab, which is the subject of the intergroup trial that we are leading from ECOG, and discuss the design and rationale of that trial. So I think you've all seen this, which really is, I think, is a landmark study that Wendy Stock published in 2008, but it actually reported a number of years ago, and I think really stimulated the much of what we've learned and are learning about today in the AYA population, showing that adolescents who were treated on pediatric protocols did better than if they were treated on adult protocols. And there are many reasons for this, as we know. A big factor is the increased dose intensity of the non-myelosuppressive drugs. Again, Wendy showed this data, and I highlight that in orange here with vincristine, corticosteroids, mainly dexamethasone here, and asparaginase. And so based on this study, again, many of you know that a number of groups have now published data taking pediatric intensive regimens and applying them to adolescents and young adults that come to adult centers. And this was one of the first studies that was published in the JCO back in 2009 from the French group. So they did a phase 2 study, the Graal 2003 trial, and then compared that to their historical experience with on the LALA 94 trial, and you can see that they saw a slightly higher remission rate, but had a significantly improved event-free and overall survival when they compared their results with the pediatric regimen to their historical data in an adult-type protocol. And you can see in the second sentence there, the bottom sentence about the increase in cumulative doses of the non-myelosuppressive drugs, but they pointed out that they didn't see as much benefit in patients over the age of 45, and they did have more deaths, as I will show you. This led to a trial that many of you participated in here in the United States, the 10403 trial, led by the former CLGB, now Alliance. But this was an intergroup study that, again, all three groups in the United States participated in. And this data is going to be presented from this study by Wendy Stock on Tuesday morning at ASH in an oral presentation. So if you haven't booked your flight yet, you might want to stay a little later at ASH this year and be some of that crowd on Tuesday morning that shows up. So we're excited to see the data from that study. So I want to talk a little bit about a very large trial that we did, again, in collaboration with the MRC NCRI. And again, this is data that was published in 2008 by Tony Goldstone. This is the UCAL12 E2993 trial, where patients went through 2 months of induction. That's block 1 and block 2 in the upper right there. And if they were in remission and they had a sibling donor, they went to sibling allograft. If they were pH positive, they could have a matched unrelated donor transplant. If they didn't have a sibling donor, they were randomized after getting an intensification with high-dose methotrexate, to get an autograft, an autologous transplant, or go to consolidation and maintenance. And this study showed that, in looking at a donor-no donor analysis, that patients that had a donor did better. And remember, this chemotherapy regimen, we will say, is more of an adult-type regimen. But you can see again that if you had a donor, you had an improved outcome. And this was particularly prominent in the standard risk patients, and these are the pH-negative patients that I'm showing here. So you can see there was about a 10% survival advantage if you had a donor and you were in the standard risk category, which I'll show on the next slide, was the high-risk patients. And this was somewhat surprising in that previous studies had suggested that high-risk patients did benefit from a donor, whereas this study didn't seem to suggest that. And you can see that the high-risk features that we utilized for this study, and these still apply today, although remember this study did start actually in the early 90s. So why did we see these different results? Well, you can see in the top that the relapse rates were lower in the patients who had a donor, whether they were in the standard risk group or the high-risk group. But unfortunately, we had a high treatment-related mortality in the high-risk group who had a donor, and I highlight that down on the lower right with the orange arrow here, that we had a 35% TRM compared to those without a donor, and this was about kind of what we have tended to expect with a myeloablative transplant in first remission, about 20%. So the older patients had more TRM with a transplant. Now, there's been a number of meta-analyses that have looked at the role of transplant in CR1 because there's been this question based on this study and others about, well, what is the optimal post-remission therapy in these patients? And this was a study that was published in 2010 where they analyzed 13 different trials and looked at non-relapse mortality, relapse, and they concluded that allogeneic transplant was superior even in the standard risk patients, and that's shown here. The p-value is 0.006. The high risk, it also favored transplant, although the p-value is more borderline at 0.007. Now, many of these studies were comparing, again, more of an adult-type regimen to a transplant, and this is actually a slide from Del Fielding that, and this is, will make statisticians shudder, but on the left side you see data from the Spanish that they published using a more pediatric intensive regimen in adolescents and young adults, and on the right is the data from the MRC ECOG trial. And you can see that in the Spanish study, the survival is at 63%, and with transplant on the ECOG MRC study, it's at 62%, so they're almost identical. So it would raise the question of if a patient's being treated on a pediatric regimen, within a pediatric intensive regimen, do they need a transplant? And I think many people are feeling that that may be the case, and so that many of us have adopted that as a practice, and that's, we'll see what the C10403 data shows at ASH when Wendy presents that. So going back to the Grawl study, I just want to point out some additional data from that study, and this is this is again that French study that I showed you, and they compared their data to historical control, and you can see that the overall survival in that study was 60%, and the event-free survival was at 55%. But just drilling down and looking at the data a little bit more from that study, and this was in some of the supplemental data that was presented in that study, you can see that, kind of as Archie showed, that there's differences in outcome as people do age, and you can see here that for the 15 to 25 years old, the event-free survival was 64%, 26 to 40 was 56%, and 41 to 60 is at 44%. And then breaking it down by age and now comparing the Grawl study, again, the pediatric intensive, to their historical group, from the LAL 94 study. And that's, and I'm sorry, this is looking at the Grawl data and looking at these different age groups. So this is all the pediatric intensive data, but you can see that age 15 to 45, it was at 58%, and then above 45, it was down to 46%, and you can see that this was largely because there was a very high TRM, 23% in the 46 to 60-year-olds when they were given a pediatric intensive regimen, whereas there was only 5% in the 15 to 45-year-olds. So I think it's fair to say that older adults don't tolerate these more intensive regimens as well. And now this is looking at the Grawl data versus the LAL data. So the blue lines are the LAL, the adult intensive regimen. The yellow are the Grawl data. And you can see that the relapse rate was less with the pediatric intensive regimen, and the survival was better. And the lower curve is showing whether you look at, the blue is the LALA, so that's the adult intensive regimen. The yellow is the Grawl, and you can see that in both these age groups, the Grawl data survival curves were better than with the LAL when you break it down by age. Again, the 15 to 45 and the 46 to 55. So even in the older adults, it does appear that they may benefit from having a more intensive regimen, but it's at the price of higher TRM. So this is my spacer slide. I had the fortune to go to Peru and see Machu Picchu this summer, so I thought I'd just show that. So now I want to shift gears and talk about the basis for the study that we're currently doing in the intergroup in older adults, and this is based on, I think many of you again know some of the exciting data that's been seen with blinatumomab, a bispecific T-cell engager antibody that combines a variable region of an antibody against CD19. So this is a target antigen on B lineage ALL cells with a variable region of an anti-CD3 antibody linked together. The idea that you're bringing a T-cell in close proximity to tumor cell, in this case an ALL blast cell, and causing that cell to lyse. So the first study that was done with blinatumomab was not in frank relapse patients, but in patients who were in hematologic remission but had molecular failure or relapse after chemotherapy. They only treated 21 patients. They gave blinatumomab in a continuous infusion for 4 weeks on, 2 weeks off, and the primary endpoint was molecular complete remission. And patients could continue for up to 3 consolidation cycles after 2 initial induction cycles. And they achieved MRD negativity in 80%, so 16 out of 20 of the patients that they treated. And these patients seemed to have a favorable survival outcome. These were all patients in blue. Yellow was patients who did not go on to transplant because transplant was allowed for these patients on this study. It's important to note some of the, I'd say, unique toxicities with this agent, although it's some that we see with more of these biologic therapies, cytokine release syndrome that is also seen with the CAR T cells. And so this describes some of that experience on this study with those patients. And then there's also CNS events, primarily encephalopathy and seizures, which fortunately are all reversible with discontinuation of the drug, but are certainly serious events. Now, this then led to a study in relapse and refractory. So these are patients that were frankly relapsed or refractory who were then treated with blinatumomab. And you can see that the CR and the CRH responses in this study were very high, almost 70%. This was 36 patients, and 25 of them achieved either a CR or an incomplete CR. Many of these patients achieved MRD negativity either after cycle 1 or at the end of cycle 2. So these were, we can say, quality remissions. Although, unfortunately, these patients still relapsed after achieving, many of these patients still relapsed after achieving these remissions, so they weren't obviously completely disease-free. And this just shows that whether patients had a prior transplant or not, this is before they were treated on this study, their outcomes were similar. And so this is data that Max Top has published, and there was a follow-up more recently in Blood in the last year or two. And so this then led to the most recent study using blinatumomab in relapsed refractory patients. The previous study I showed you was primarily in Europe, and this was an international study conducted here in the United States and in Europe. This was they treated 189 patients. So these patients, again, relapsed refractory. They got 2 cycles of blinatumomab, initially starting out at 9 micrograms per day for a week, then escalating to 28 micrograms. 2 cycles. If they achieved remission, they could go on and get an additional 3 cycles. They could go off to transplant, obviously, if they had a donor and they were suitable for that. Now, these patients had to have, in the previous study, it was greater than 5% blasts, and they were mostly in first relapse. This study allowed, they had to have greater than 10% blasts, and it included patients in later relapses. So this was a higher risk group, and so the results were not quite as good, and this was, again, presented at ASCO by Max Top. And this study has been submitted for publication. And this shows the patients that were treated, again, 189, mostly males. You can see the breakdown of the age groups, and you can see that a fair number of these patients had 2 or more prior salvage therapies, and a third had a prior transplant, and this shows the percentage of bone marrow blasts. And so the CR rate in this study was 43%, not quite as high as in the previous study, but still quite a respectable figure for this population of patients. And you can see how that broke down, the CR and CRHs, and then there were 9% that were hypoplastic or aplastic. And also you can see that many of these patients achieved MRD negativity. And this shows the survival curves, the overall survival of the whole group on the top, and then on the bottom is the responders versus the non-responders in yellow. So this is one of the lawnmowers at Machu Picchu that I took a picture of. So I want to talk a little bit now and just describe to you the study that we're doing. Again, this is an intergroup trial, E1910. It's being led by our group, ECOG. And basically, we're taking this promising agent, blinatumomab, and moving it to the upfront setting to see if we can improve the outcome of older adults. Archie showed the very sobering data of how older adults do in ALL. And this is a complicated schema, but basically, we took the previous ECOG MRC trial that we did and incorporated blinatumomab into it. This is a randomized study, 1-to-1, where accrual goal is 360 patients. So patients undergo 2 cycles of induction and then an intensification, and then they're randomized to get 2 cycles of blinatumomab or not. And then if the investigator wants to take them off to an allotransplant, they can. Otherwise, they get additional consolidation and 2 more cycles of blinatumomab toward the end of consolidation and go on to maintenance. Whereas those not randomized to blinatumomab will get consolidation, can also go off to a transplant and go on to maintenance. And I'm not going to go into all of the details of the chemotherapy. It's a standard BFM type regimen that you're familiar with, but this just shows some of the chemotherapy that we're giving, the intensification here. It's where the randomization occurs, and here's the blinatumomab or no blinatumomab, and then going on to either consolidation or to transplant. Again, further consolidation with the additional blinatumomab and then maintenance therapy. And we are going to be measuring MRD in this study centrally. This will be done in Elizabeth Paetta's ECOG, or her Leukemia Translational Laboratory in New York, and you can see the different time points where we'll be doing the MRD measurement. This is going to be done by flow, and we tried to match up the time points in each of these two groups. So the goal of this study is obviously to see if blinatumomab can improve overall survival in these patients. So these, and again, this is for BCR-ABL negative B lineage ALL, obviously. And we want to try to look at both the overall population and also see if the MRD positive, the patients that are MRD positive at the end of, or at the time of randomization after induction and intensification, if they benefit, and as do the MRD negative patients. So we did intensify this regimen. We took some of the features of the C-10403 trial, which was based on a COG trial. We did change how the daunorubicin was given. So we did de-escalate the daunorubicin, increase the cyclophosphamide dose somewhat. We extended the second cycle of induction from 4 weeks to 6 weeks, and we added some additional doses of pegosparaginase. Although I will say that patients 55 years of age and over, we are not going to give them pegosparaginase except for one dose in one of their consolidation cycles because of the increased toxicity that older patients see with pegosparaginase. We did set the lower age limit of this study initially at 40 because that was the age up to which the C-10403 study went, and a successor study is being planned, but that's been delayed, and so we went down to 35, and now we've gone down to 30. So this is going to encompass patients between the age of 30 and 70 so that we don't overlap with the upcoming Alliance study, and we also didn't want to, our statistical assumptions were based on older patients, and so if we went down to too young an age, that could impact that. We were going to blind the flow data that was done centrally. We recognize that many institutions will do it in their own institution. We're rediscussing whether we're going to keep that blinded or not right now. That was our initial intent. These are some of the statistical assumptions. And it was again based on our previous study. We estimated a CR rate at 88%, assuming a dropout rate. And in the control arm, a 30% cure rate with an 11-month median survival. And we hope to have a 80% power to detect a 43% reduction in the hazard rate, so an equivalent to improving the 3-year overall survival from 37 to 57%. And then again, this study is going to be challenging to accrue to because it's a subset of older adults with ALL, so we relaxed the statistical assumptions a bit in the MRD positive patients because we didn't feel we could increase the accrual to a much larger number. We anticipate this trial is going to take about 5 to 6 years to complete, and we didn't want to go beyond that. So these are some of the assumptions that we had for the MRD positive patients. We didn't want to miss a response in the MRD positive patients if there perhaps wasn't one in the overall group. We just don't know. One would think and hope that this would benefit all patients, but we wanted to be able to assess that as well. So I think that's my last slide. I was in Israel a couple of years ago and took a picture of this sign. We worry about deer in Minnesota. In Israel, they worry about camels near the road. So I didn't know if anyone would applaud, so I brought my own applause slide. So thank you.